Thank you very much. So this talk will be a little different because the focus here is on clinical data rather than the more scientific data that you've been speaking about all morning. But I hope you will regard this as a complementary and important area for you as well. So firstly, just a little bit of context to remind you. We have an aging society, not only in Europe, but actually across the world, with increasing comorbidity and yet economic pressures on health systems. There is a real need for us to accelerate the discovery of new medicines, and I've been hearing today about ways in which we can improve diagnostic, we can target therapies better. This is exactly what we need, but we need this to be accompanied, of course, by demonstration of cost effectiveness and value, as a couple of people have hinted, so that we can really show why this is an appropriate area of expenditure in order to improve the population and their health. To complement that, we have a shifting, evolving, and hopefully improving landscape around health data. We have electronic health records in particular that are growing in richness, growing in sophistication. And here are just some examples of some of the properties, but things that might be important to you when you're looking to correlate molecular findings, metabolic findings with clinical pictures. What I would nickname in the old-fashioned era nature and nurture. There is now this new exposome term, which I think is the synonym for nurture, but I'm not quite sure. That landscape, you need lots of fine-grained clinical data, and what we're seeing now increasingly is a connectivity. So the data captured in general practice, the data in hospitals, not yet, but soon becoming more combinable, so you can co-interpret data about a patient's lifetime health story as opposed to just pockets of disease-specific, more and more coding, more and more computable data with better semantic interoperability, making it feasible to do the kind of research that you need. So we do see that world. Interoperability is vital importance to healthcare as well as to research. And examples of what health has been trying to do, what e-health interoperability has been trying to do, is to enable things like clinical guidelines and care pathways, decision support, alerting, to help clinicians to be able to work with combined integrated data and to receive prompts and alerts and reminders that enable them to be better evidence-based and safer as practitioners and to collaborate. There's an important need for us to engage much more closely with the patient, with the citizen, and so what we need, and this is something where at the moment I'm fighting an uphill battle, we do not yet have a strong market drive to stimulate personal health records and personal health systems to use interoperability standards. So we are now inventing new silos around the patient, and what we need is to bring these worlds together, and that's a real uphill challenge. Health systems, in order to make strategic decisions, not just treatment effectiveness, HTA type things, but also to orchestrate care planning and make national decisions, they need better quality data than they have today. Today they're often working with very coarse-grained, very crude coded data, secondary coded data, and we really need to see them moving to finer-grained data so that they can reshape health systems around targeting better outcomes. That's relevant to you because actually the end game of your community is improving clinical outcomes. So effectively, if we can help health systems to be more outcomes focused, it will favor adopting your kind of innovation. So I do see that as important. And that's, of course, where there's a further issue about whether, and this is a question in a way to you as a community, but it's a question I've also asked to the genomics community, is are you in danger of creating new generation data standards that work for you and don't connect to healthcare? And the connection point, perhaps between these worlds, is probably the word phenotype. The word phenotype means something to you. I've heard it, 100 times today. To an average clinician, the word is foreign. It's unknown. We talk about clinical data. We don't talk about phenotype. We talk about a patient. their health status, their health situation. So just remember that, not just the word phenotype, but the standards used to describe these people need to be aligned, or we're going to have further silos. Now, this is a non-interoperability issue. Did so much work with PowerPoint to get the fonts to all fit beautifully. Then you go to another computer and they squeeze. I wasn't wanting you to read the small print. All I want you to do is to understand that there are many, many information standards covering different areas in the big font that need to be taken on board when you think about interoperability. This is the electronic health record standards landscape. This is not all the standards. These are only examples. There are many, many more standards that people like me have to understand and be familiar with that need to work together and help create interoperability. The areas that probably matter to you most are this family of standards, things that deal with concept representation. You're familiar with words like ontology and terminology. You will know terminology systems. Most of you may use ontology as part of your research. That's one world, but unless you combine that with information models and capture in a robust way the context of individual clinical entries, you will risk misinterpreting the data. And so do please see this as a three-way relationship, and that unless you look after context as well as concepts, you misinterpret. Let me give you an example of what I mean by that, because then you'll get it. Let's imagine that there is a diagnostic code for chronic obstructive pulmonary disease sitting in a patient's electronic health record. And if you ran a query, you can pull out this code and say, COPD, I know what this patient's got. Do you? So let's consider, it could be a brand new diagnosis made today as a result of lung function tests. So not only do you get the code, but you get the date, and the date tells you when it was diagnosed. That could be useful. But it might be only a suspected diagnosis. The code is in there because it's only a suspected diagnosis. It could be just one of several diagnoses being considered. There could be other codes sitting in that entry that you've ignored in your query, but are all part of the family of suspicions. It could be just a query written on an order for lung function tests. Now, if you've ever tried to order tests at weekends or out of hours, you have to exaggerate to get the pathologist to get out of bed and come and do a test. So a query diagnosis on a test has another cultural overlay on top that means it may not reflect the full truth. It could be an excluded diagnosis. Did you look in your query for any codes that might associate this COPD with a negation? Not COPD. I don't think the patient has COPD, etc. This happens too. Junior staff working at night, they pop in a diagnosis which later on in the morning in the cold light of day becomes disproved. But like any good version tracked provenance guarding record system, the old data remains. So you might be pulling out something that's been disproved later on. It could be that it's just written down as why I'm giving the patient a flu vaccination. So I've not made the diagnosis today. They may have had the diagnosis for 20 years. So the dates around this code are not meaningful in terms of disease progression. Who's the subject of this COPD? Maybe it's not the patient at all, it's the patient's mother. Maybe it's a risk factor. No one in the family has COPD. It's just a risk factor. Maybe it's something the patient's worried about because they've got a friend, they've heard about a neighbor that had a very bad experience. Do you know what upcoding means? Some of you in the room know what upcoding means. If you have a patient that is kind of asthma, kind of chronic, it's a little bit on the borderline, but your hospital gets a 3 times greater reimbursement for COPD versus asthma, and you're a head of department, what would you do? Don't answer the question. It happens. And of course, it could be a simple data entry error. Somebody hit the wrong key. They've saved it, and maybe a few hours later, somebody said, what did you mean? That isn't what you meant, is it? No. Error corrected. Old version remains somewhere in the system for auditability purposes. And then you've got actually the size and complexity and the breadth of an electronic health record. So this is just going to flow up on screen. It gives me a few seconds to pause and have a sip of water while you're observing the screen. There's a lot of stuff in an EHR. And then there are specialties that have their own way of looking at a health issue. A psychiatrist and a cardiovascular specialist may describe the patient very differently. So when we're trying to build interoperability and semantic interoperability solutions, doing everything on this screen is just too hard. So what you will find is that the progress is being made in what we would call high priority areas. We look for areas of clinical data that are most important to share computationally. Well, we can share today human readable by fax. We don't need a computer for that. But for computability, what matters most? Things like prescribing safety, conditions, allergies, medication lists, so that a new prescription can be cross-checked, etc. That's where we're trying to prioritize the efforts towards interoperability. But it's far from easy to get the marketplace to move towards standards. If any of you have worked with hospitals, with clinical data, with GPs, and you're listening to me now, you're saying, Dipak, you've got a nice list of standards there. When we go to the vendors, when we go to the hospital, we find it's a mess. In the hospital, 20, 25 databases, the lab system doesn't talk to the ward system, we can't get a holistic patient picture, and 2 different hospitals, totally different worlds. What are you on about? Well, it's very difficult, actually, to get standards adoption in our lovely world, because the people who really are the drivers are the people with the money, the funders of healthcare, and they, in the end, dictate the information flows that they're willing to do. There are these players who purchase, provide ICT solutions. There are the people who use it, the end users who create clinical data and access clinical data. And then there is this bottom tier of people who have nearly zero influence on ICT strategy or spend, but are the people we claim are the beneficiaries of all this e-health investment. All the multi hundreds of millions spent across Europe in the last decade is for them, but we haven't actually engaged with them much. Because what we're trying to do is to optimize reimbursement, we're trying to optimize business efficiency, and at the bottom end, clinicians, they're trying to optimize their workload. So they're the drivers behind ICT spend, focused on these kind of commodities, whereas what we need to do is to shift this landscape away from all these perverse incentives towards an era in which we can say that the decision makers and the policy makers and the insurers with the budgets offer financial incentives towards ICT that delivers integrated person-centered care, and that these purchasers don't buy systems for their care organization, they buy systems for care collaboration. And that what we want to see is that our healthcare professionals and others and the research sector are targeting patient-centered solutions, and that actually we are engaging the citizen in the co-creation. So this is the journey we're on, but it's a painful journey, it's a slow journey, and you can help, please. So I'll just quickly skip the rest of that slide, which I can't do so quickly on a Windows computer. You can do it really quickly on a Mac. What we have to do is to champion collectively the concept of learning health systems, where on the research side, there are things that you do for a living, that you help with parts of this cycle, where you need good quality clinical data, but you help generate solutions that then leverage computable clinical data so that we can improve care around diagnosis, support risk management of patients, improve clinical outcomes, and also monitor safety. So this virtual cycle of knowledge discovery, knowledge application, improved patient outcomes, and hopefully, therefore, better targeted health resources is something where we work together, because there's one commodity we all need: better quality health data. We all need that. You need it, healthcare needs it, and that's what I'd like to see us do. Now, I'm going to just briefly mention 2 IMI projects in which I'm involved, just to let you know that progress is being made also on the research side. EHR for CR is a project that's actually just finished successfully, so I'll tell you what we're doing. And it's a project that has been trying to look at how we can use electronic health records across hospitals to better identify patients who may be suitable for clinical trials. And that's really what the project has done. It's a fairly substantial project with a large public-private grouping, so a lot of pharma as well as academics and others working together. And what we've basically done is completed the job, and we're now in sustainability mode. What have we done? What is the job we completed? There is a platform now created that can connect to multiple systems. It can take queries from a research sponsor, which could be pharma, could be academic clinical research, it could be any of you, or it could be a charity or a patient organization wanting to look at where its people are. It can connect to multiple hospitals and return back to the research sponsor indications of the number of patients who might meet those criteria. And it does so in a secure way, and then it supports a hospital with assembling its cohort. How does it work? Well, a hospital will, on this dotted circle here, carry out an extraction process from its operational EHR into a de-identified repository that is then used as the target for the platform. The platform then, so that mapping, by the way, is supported through tools, and what we hope over time is more standards will result in an easier process for that mapping. The research sponsor only has secured access through the platform with credentials and other verification. What comes back to the research sponsor is only patient counts. They never get subject level data. They're only allowed to know the frequency distribution of their eligibility criteria at each of the sites. So they can tell where the patients are, and they can tell how many and which criteria they're meeting, but they can't ever narrow down to a single patient. And these at the bottom here are examples of privacy protection methods that are being used. The topic of privacy protection and ethics has come up, and Heidi gave a talk this morning. Today, I can't touch that subject in any depth because I'm on the interoperability topic, but there's a lot of work we've been doing in that area. So that's another touch point with Phenomenal that I hope we can work on in the future. What I will just give you as an example of is that these are the kind of query statements and or not kind of operators can be added here. So you can profile the patients you're looking for, and then you can get back the answer as a distribution across different sites, different countries as to where these patients are. And this kind of infrastructure environment is an example of an infrastructure that may intersect with some of the infrastructures that you create around sharing metabolic data. This sustainability of this initiative is now moving into an early adoption program called the Champion Program, and you can ignore most of the slide, but just look at the top. A series of pharma companies have all agreed to put new money on the table to actually start to use the platform for early trial experiences so they can get better experience of its use. And there's a whole series of technology partners. We're now starting to grow a network of hospitals who wish to connect, who wish their data to be used for research. And please remember that although these are pharma clinical trials, the driver for a lot of hospitals to connect is not that. Yes, that's a financial driver, but they want to reuse their own data. They want to learn from their own data. So what we're seeing is a real hunger right across the ecosystem for learning from the data. And what they tell us is that if this takes place, if that learning health system cycle becomes operationalized, they will have internal incentives to improve data quality, which they recognize is an important area needing incentivization and investment. You probably have experience, some of you, of poor quality clinical data, lots of missing values, lots of imprecise observational facts. They also want to improve their data. Another project that may again be of interest to you, EMIF, which is still in the progress, not yet finished, is looking at how can it build a federating platform to bring together many different kinds of data source, not just electronic health records, which I've spoken about previously, but things like disease registries, biobanks, longitudinal cohort data. Can these be brought together into a co-interpretation space? So in this diagram, the only complicated diagram I'll show you, much less complicated than your diagrams, I should say. On the left-hand side are a series of data sources that could be cohorts, they could be EHRs, they could be biobanks. They will carry out an export, a bit like you saw in one of my previous diagrams. They'll be using a common ontology, but they'll be mapping their data. And then what EMIF will provide is either a browsing catalog where you can at least find the data sources that meet your needs, but not get the data directly from EMIF. Then you negotiate with each data source directly, or it can offer a kind of just-in-time secure safe haven environment. So actually, if you're combining data from 3 or 4 data sources, there can be a sensible place in the middle that's well protected and well governed. And we're now in the middle of doing the ethical code of practice and the service level agreement type documents that would be used for this kind of thing, and looking at data sharing best practice. So we're just in the middle of working in those areas. So this is something to watch for the future because it may be useful, and it sounds like the kind of infrastructure that the phenomenal infrastructures might connect to in a very helpful win-win way. So this is a slide that I've just put up to tell you what you already know. What we are trying to do is to get more precise, aren't we? What we're trying to do is to use a combination of high-fidelity techniques, whether it's clinical pictures or whether it's molecular pictures, to try to profile patients more and more precisely so that we can be more and more accurate either in diagnosis or treatment. So this is our end game, really, is to be able to do these kinds of things. And I want to just draw attention to a small difference of language here that does take place. Let's see how this works. Answer very badly. Oh, this is the trouble with them. So I don't know quite how to resolve this issue because you're not seeing. No, they've gone white. Okay, so I've got a difficulty here that I can't resolve, I think. Sorry about that. Okay, what I may just have to do is live with the fact that you don't know what's on these circles here. Okay. Sorry? Oh, okay, that's a good idea. That might work. Yeah, okay, then at least you'll see it, even without the pretty colours. Could you make all the could you make the font black?
The font black?
So if
¿Qué letra? Ah, vale.
yeah, let me just do it this way then.
Es que,
Yeah.
ya, pero tengo que...
If I do that, and then just do that. Yeah, that's
Yes,
good
yes,
enough. Now, where do I go back into presentation mode? Sorry.
No.
Where's the icon?
You're
Oh, it's
welcome.
down there. Okay. All right. Thank you. Good thinking. Good thinking. So imagine that this is a nice color and that there's a different colored writing and that it's very beautiful. So just imagine that. So look, we have the clinical understanding of disease. We have the molecular understanding of disease. And these come together under paradigms that we now know: evidence-based medicine, the discovery of innovative medicines, patient stratification, targeted therapies. But on the other side of the story, we have health systems that have a finite capacity, a finite capability, a finite budget. And then we have patients who have preferences, who have goals, who have personal situations. They're on low income. You want them to eat lots and lots of fresh fruit, but actually fresh fruit's very expensive. You know, they're smoking because they're stressed and life is miserable and they don't have the ability to stop smoking. So you've got people with real life situations on the other side. Oops. And so then this gives rise to things like new ways in which we're trying to re-architect health systems, new models of integrated care, new reimbursement models to change the way we reward healthcare providers, and then patients themselves being more inclusive. And then we have these two terms, and I want you to think of both terms because they're both important. Personalized medicine has occurred a few times today in the conversation, and I believe that this is how you mean it. But I want you to also consider personalized care, which is when we're looking at the service delivery to individuals that is taking into account their wishes, their needs. And as we personalize, what we need to do is to be mindful of both. So neither is right or wrong, but please remember both terms, Personalized medicine, personalized care. Our end game is that little tiny intersection in the middle. That's where we're really going to go, I hope, in the longer term. We won't get there without big health data, and so we need that. And of course, as we move towards the citizen, we're seeing a real explosion of their data coming into this world. And I didn't hear so much about that today, but I guess as you make sense of metabolic changes and things I don't quite understand called flux, which sounds exciting, but I don't quite understand what it is, I apologize. What I hope is that we can also start to get more information about the patient and their everyday life, because they spend so little time actually in contact with healthcare systems. So in a way, we're at a really, really exciting time. The quantity of data we may have at our fingertips is growing hugely. And it feels like the moment for big data has finally arisen, with not only data from healthcare, but data from citizens growing, expanding, and so on. And then when you look at the resources that might contain these data, we have a whole series of places within the healthcare ecosystem in this kind of orangey color. But we also mustn't forget, in the yellow color, a number of data sources that are coming out of the patient-centric world. And then, in a slightly greener color, are areas that are not classical health, but are also relevant to health, that we might need to also consider if we're going to get a holistic picture of the patient. But before you get too excited, please remember that much of the data you rely on in clinical care is coming through some rather painful processes. We have busy junior staff who don't really feel incentivized to document well. We have systems that have not really been designed well to support person-centered care, clinical care collaborations, etc. And so we have in the blue the kind of downside, that life is a bit harder than you think. But what we want to end up with is this area of lovely green properties. This is what we want our data to look like, don't we? You all want this. These are your holy grails of health data. And we need to get there. So we need to somehow move the energy from the blue, which is a little bit negative, towards everybody really wanting to champion that top section. And that really means we need to change the culture. And that goes back to my learning health system cycle. We need a culture that really wants to put health data to good use. And you are part of that, because you want to put the health data to good use. So you're part of my army of people creating a pressure, a good, healthy pressure for everybody to co-create better quality data. And that, in a way, is what gave rise to us creating this institute. We initially needed to create a not-for-profit trusted space in order to provide external governance on that EHR4CR platform, the Champion program, and its sustainable environment. But what we actually did was look at many other projects that also had elements that needed sustainability, and realized that what we should do is join forces. So we've created an institute that actually brings together the needs of multiple projects to sustain and to go from an R&D phase into an evolution partnership phase. And that's really why we created this institute. That's its mission statement, which you can see is nice and flamboyant, as all mission statements should be, but it's pretty generic. And look at the bottom line, it's about optimizing health and knowledge discovery. So you, as knowledge discoverers, are part of what we want to try and help, and that's our goal. So what we're trying to achieve in this new institute is to play a central role in governing the ecosystem in which health data is reused for research. We are working on good ethical principles, codes of practice. We know there are many other codes of practice out there, and colleagues in our institute have been involved in creating some of those. And so we do look in the future to harmonizing codes of practice. And I would like us to touch base with the work that Heidi was describing. There's someone in the audience, sorry I can't see you now, but Heidi was describing earlier some of those issues and challenges that you're facing. Let's help create harmonized solutions there so that everybody can benefit. We need to promote standards adoption, and in particular to bring together the world of clinical research standards and clinical care standards, as you know, and then to also work in areas of promoting to society. And perhaps what I'll just do in the interest of time is just jump to this last slide. You all know that if you look at the newspapers around health data, what you find, if you were imagining your mother or a member of the public thinking, where do they think of health data? Where does health data appear in the news? The answer is it's only one place: scare stories. CDs lost in the post. Laptops leapt on a train. Somebody's put some data on the internet. So in general, people think of health data and their privacy as an area of anxiety and nervousness. There's a lack of trust in society about you lot, who may be being bravado cowboys and cowgirls with their data, but you'll leave USB keys lying around in a laptop in a public place and all that stuff. So what they see is that the safest thing to do in general is to say no. And if you look at privacy protection officers and most healthcare organizations, they take a very conservative view on any request to access data. Some of you may have had that experience. What doesn't happen is anybody saying there's a great public good from your data. So we are starting a process through some interviews with patients, and they're already on our website and more are coming, and other things, where we're not trying to say, trust everybody, they're perfect. You look pretty imperfect around the room. It's not that, but we want to say to society, look, a huge amount of good comes from your data. And I've just sat here in the room today hearing fantastic innovations and advances. Society doesn't understand it. They won't understand your slides. Even I didn't understand half of your slides, I'm sorry. But we need ways of conveying to society the magical excitement that's coming from using their data. If you look at all newspaper reports and BBC website reports of scientific innovations in healthcare, they never mention the fact that 150,000 patients' records were de-identified and examined in order to arrive at that finding. They don't mention it. The public doesn't get that message, so we're going to do that. We want to really make the public realize there's a balance to be found. There's a partnership to be found in getting privacy protection and scientific advance right. Thanks very much.